Good morning, ladies and gentlemen, and our listening audience today, and to all those serving aboard the Navy ships at sea. Welcome to the first session of day number 2 of the PFF Educational Symposium. It's called Pulmonary Fibrosis 101 and Patient Case Examples. We're glad that you're joining us today and look forward to a full day of education and networking. I'm Joe Lasky. I'm the PFF Chief Medical Officer and also a professor of pulmonary and critical care medicine at Tulane University. I have a few housekeeping notes to begin with here. If you have any tech issues, please click the green message button, which is located on the lower right-hand corner of your screen. For any Pulmonary Fibrosis Foundation questions today, please click the Help Desk button on the menu ribbon at the top of your screen to connect with the PFF staff. The speakers will be answering questions related to today's talk at the end of the session. So throughout the session, please submit your questions by clicking on, I'm going to click here, on this Q&A tab in the interaction panel to the right of the video. All right. And we will answer as many questions as we can in the 15 minutes that we have after the presentations from our distinguished panel of speakers. So let me begin now here by introducing our panel of speakers. That's Dr. Chad Newton, and Dr. Catherine Kaproth-Joslin, and Dr. Yasmin Bhatt. Briefly about them, Dr. Newton completed his medical school, internal medicine residency, and pulmonary and critical care fellowship training at UT Southwestern. And while in fellowship, Dr. Newton developed a clinical research interest in pulmonary fibrosis. He serves as the Associate Director of the Interstitial Lung Disease Program at UT Southwestern and maintains an active practice there. Dr. Catherine Kaproth-Joslin, MD, PhD, is currently an associate professor in the Department of Imaging Sciences at the University of Rochester in Rochester, New York. That's the radiology department to the rest of us. She received her degrees from the State University of New York and Upstate Medical University in 2009 and completed her radiology residency in 2014 and a combined fellowship in breast and advanced cardiothoracic imaging in 2015 at the University of Rochester. Following fellowship, she joined the Department of Imaging Sciences at the University of Rochester as a cardiothoracic imager and became division head of cardiothoracic imaging in 2022. Dr. Yasmin Bhatt is a consultant in the Department of Laboratory Medicine and Pathology at the Mayo Clinic in Arizona. She is part of a busy pulmonary consultative service and has published numerous articles and book chapters in the field of pulmonary pathology. She is the author of a recently published textbook, The Atlas of Pulmonary Pathology, a pattern-based approach. Dr. Bhatt is active in the College of American Pathologists and the Arizona Society of Pathology. The speakers will provide an overview of pulmonary fibrosis. Then they will talk through a couple of patient case examples, helping to highlight how the diagnostic process of pulmonary fibrosis works and how the teams work together to formulate a diagnosis and care plan. So here's Chad.
Thank you very much, Dr. Lasky, and thank you to the organizers and to everyone that's attending today. So I'm going to discuss really just an overview of what we consider pulmonary fibrosis. So here I've got a couple of stylized representations of lungs. We've got a right lung, a left lung, and a trachea with airways in the middle. And we start looking at smaller units within that lung. We have smaller airways, and we have what we call alveolar sacs, which are little tiny balloons that participate in the entire function of the lung, the gas exchange within the lung. If we look at those air sacs kind of under a microscope, we see that we have small airways where air moves in and out down into the alveoli or the alveolar sacs. Oxygen then travels pretty easily across the walls of the alveoli through what we call the interstitial space between the alveoli and a capillary or a blood vessel. In pulmonary fibrosis, though, we end up getting scarring or this green material. It's not actually green, but this scarring material that fills up that interstitial space and makes it much harder for oxygen to move from the alveolar sac into the blood vessel. And that's what ends up causing the symptoms and the physiologic defects associated with pulmonary fibrosis. So if we look at this on what we typically use as a high-resolution CT scan, we can first look at normal lungs. This is what normal lungs look like in people. So we have lungs that are on the right side and on the left side. They're basically filled with air, and on a CT scan, air is generally black. then we have these really thin, kind of wispy white lines within the lungs, and those are normal. So those are blood vessels and supportive structures. And in someone who has pulmonary fibrosis, this is quite different looking. So we have these thick, kind of gnarly looking lines within the black areas of the lungs, kind of along the edges here, and that represents scarring within the lungs. And so this scarring process ends up causing really the symptoms that we see in patients who have pulmonary fibrosis. These symptoms are generally, shortness of breath and cough that are progressive. But it's really tough to know, if a patient that comes in with shortness of breath and cough have pulmonary fibrosis or not. So we have to start thinking kind of broadly on causes of kind of shortness of breath and cough and progressive symptoms over time. And we end up using terms that sometimes are confusing for patients and occasionally even confusing for some pulmonologists. So we have this broad term called interstitial lung disease, which really is any form of diffuse lung disease that causes either inflammation or scarring. And a subset of the interstitial lung diseases are termed pulmonary fibrosis. Pulmonary fibrosis is another generic term that describes a group of over 200 lung disorders. So this is not a specific diagnosis. This is a group of lots and lots and lots of diagnoses. So within those diagnoses, we have lots of different, sometimes confusing terminology also, but this kind of gives you a framework of some of the words and terminologies that we use. As I mentioned before, all of these conditions can cause two primary symptoms, shortness of breath and cough. But this is not unique to pulmonary fibrosis or interstitial lung disease, right? Patients with asthma and COPD and even lung cancer can have shortness of breath or cough. But when we start asking specific questions about their cough, we start noticing patterns that tend to be a little bit more typical in patients with pulmonary fibrosis. These symptoms tend to be chronic, meaning they don't come and go. They're there all the time, so they're persistent. And they can even be progressive, so they get worse over time. So seeing those types of symptoms in someone with the CT scan that I just showed you suggests that a patient does have pulmonary fibrosis. But we don't stop there. So we have to know not only that they have pulmonary fibrosis, but we have to start thinking about what is actually causing the pulmonary fibrosis. What is the one of the 200 potential causes that's there? And there's lots of different ways in which these can be broken up, but we typically put them into different categories. So we can have medications that are commonly used, people are commonly on, that can cause scarring in the lung. There can be exposures at work or at home that people are breathing in that can cause scarring in the lung. There are systemic disorders, so disorders that affect lots of parts of the body and just happen to also affect the lung that can cause problems. We all now know that certain infections like COVID-19 can leave residual scar in the lung. And then there's what we call idiopathic forms that really don't have a clear cause or a reason that they occur. They kind of occur for no good reason that can cause scarring in the lung. So when we start trying to figure out why what is causing the scarring in the lungs, we go down this pretty involved diagnostic pathway. So this starts with history and physical exam, where we spend a lot of time talking with our patients about lots of different things. So we want to know about their history of their symptoms and their medical conditions, but we also need to know what type of exposures they may have had during their lifetime. So this is things at home, things at work, and even getting into potential medical history of their family members to know whether to start narrowing down from 200 down to a smaller number of potential causes. We then do directed testing to get more information. The workhorse of this testing really is the high-resolution CT scan, where we can see the pattern of involvement of scar in the lung and even start grading severity of the lung impairment using pulmonary function testing. Sometimes we're able to render what we would consider a pretty confident diagnosis of pulmonary fibrosis and a specific cause just using this information. And if so, we can then institute a management plan. But sometimes we can't, and we might need to even consider doing lung biopsies or just go back to the patient and get additional information regarding some of their history. As you can imagine, this process is pretty involved, and so it's difficult for one person to be able to accomplish all of the things that we need to do to render a confident diagnosis. So we lean on our colleagues in radiology, pathology, rheumatology, and this often requires multiple people. So it's not just one person representing each group. It's kind of an entire team that gets together and discusses our patients to not only come up with what we think is the most likely diagnosis or consensus diagnosis, but also start really putting other things together, including additional workup if we don't exactly know what's going on, and even come up with an optimal treatment strategy for each of our patients. So it truly does take a village, not only to come up with a confident pulmonary fibrosis diagnosis, but really come up with the appropriate treatment plan for our patients. The reason it's important to start narrowing down all the potential causes of pulmonary fibrosis to one thing is that if we are able to put a label on it, then we glean a lot of information from that label. So we start to understand a little bit better on what we would expect from a behavior standpoint over the next several months or even the next several years. We get a better idea of what is the optimal treatment for this type of lung disease. And we can even get an idea of what are some other manifestations that we may expect over the next several months or next several years that may pop up. Things like skin disease or joint disease and these systemic disorders that can affect quality of life, and those are things that we need to be addressing up front. As an example, I'm making a table here with 3 different pulmonary fibrosis diagnoses. We've got IPF or idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, and connective tissue disease. These are common causes of pulmonary fibrosis, and they all occur for different reasons. They can be autoimmune inflammation, or inhaling different organic materials like mold or mildew. And in the case of IPF, we don't exactly know what causes it, but we know what it looks like, and when it shows up, we're able to make that diagnosis. But as you can see here, the behavior of these 3 diagnoses is actually different. So hypersensitivity pneumonitis and connective tissue disease tend to have a more favorable prognosis and a less progressive disease course compared to pulmonary IPF. In addition, we treat these a little bit differently. Some of these diseases we use anti-inflammatory medications, and some we use antifibrotic medications. So putting the appropriate label helps us come up with these treatment algorithms. And again, as I mentioned before, like in the case of the connective tissue diseases, there's often other organs that are involved that we need to be mindful of. We tend to have this need to know exactly what's causing the pulmonary fibrosis in every single patient. Not only physicians have this kind of tendency, but patients too. We want to know what's causing it. That's not always possible. Some patients were not able to put a definitive label on their disease, and that's okay, because regardless of the label that we put on it, it's important that we are monitoring each individual patient over time so that we can recognize when things start changing or if they're going to change, and we can adjust our management strategy. So the way that looks in an actual kind of patient is, let's say, this is kind of akin to something I commonly see in my clinic where patients initially come in and they have pretty preserved lung function. So this is visit 1. They have mild symptoms, lung function looks pretty good, and we go through this diagnostic algorithm and bring them back for visit 2, and their lung function is about the same. We've rendered a diagnosis. Now we know what we're dealing with. And maybe it's a diagnosis in which doesn't mandate early initiation of treatment, but when they come back for visit 3, maybe they have a decline in their lung function. And that's a red flag. Something is changing and we need to adjust our treatment strategy. So here we may initiate patient on an appropriate medication. And then we have to keep following, just even though we've got them on medicine now, we need to know whether it's working. So in the ILD or pulmonary fibrosis world, working means that lung function and markers of disease appear to be stable. So so on visit 4 and visit 5, we see really not that big change in lung function, meaning that things have stabilized. And that is our goal. Our entire goal of therapy is to prevent this progressive decline in lung function or progression of symptoms or progression of scarring by slowing that process down. And it's sometimes difficult to know exactly what progression is, right? It's kind of this almost nebulous term, and there's a lot of research that have gone into defining objectively what progression is. But from a patient standpoint, really progression means that things are changing. So typically we are noticing more symptoms or more progressive symptoms. There's a decline or a change in the lung function or need for oxygen supplementation or ability to do activities that they were previously able to do. We can follow this by CT scan, right, and see that the lung fibrosis itself is getting worse or is changing in some way. And so our approach to treatment and management really is looking for markers of progression, because that signifies that maybe we need to adjust what we're doing, either intensify treatments that have already been started, so increasing doses, or maybe even switching medications altogether. So usually when we start talking about progression, patients will often ask me about prognosis and life expectancy. And that's actually a difficult question to answer for an individual patient. We do have some ideas based on diagnoses and groups of patients, but for any individual person, prognosis is actually highly variable and depends on lots and lots and lots of factors. So not only what is causing their pulmonary fibrosis, but maybe how have they already been behaving? Are they progressing or not progressing? How severe is their disease or how mild is their disease? Are they actually responding to treatments that we've put them on? And then even other things like age and gender and other comorbid conditions can impact someone's individual prognosis and life expectancy. So I encourage patients always to have a candid discussion with their provider to get a better idea of what the provider is thinking regarding their individual expectations. And the last thing I like to talk to patients about really is about living with pulmonary fibrosis. We often ask questions about, are things getting worse or are they changing? But we have to remember that we have to encourage patients to enjoy life and live. And so I always tell my patients, remain active, do whatever it is that you want to do, exercise regularly and maintain your fitness so that you're able to have the stamina to do whatever it is that you want to do. I encourage my patients to talk to me if they notice changes. So they need to let me know, because otherwise I might not know. If things are changing, then maybe we need to adjust what we're doing from a treatment standpoint, like I mentioned before. I also like to know about side effects. Unfortunately, a lot of our medications can cause side effects, and some of these side effects can be easily mitigated with modifications to lifestyle and diet changes, and even adjusting the doses or the times of the medications. So those are things that we want to know about so that we can make you feel better. I also encourage my patients to seek out as much information as possible. So, joining symposiums just like this, or seeking out information on the Pulmonary Fibrosis Foundation's website, or even through local patient support groups where you can talk to people, patients and caregivers that are going through some of the same experiences that you're going through now. That's a source of a rich source of information. And then I also encourage people to really consider participating in pulmonary fibrosis research. The only way that we're going to be able to really improve patient outcomes, improve our diagnostic process, find new medications is really to partner with patients and caregivers to help us identify these things, and even lean on the patients to tell us what are things that we actually need to be researching, where are we falling short. So I encourage everyone to at least consider participating in research and talk to your local providers about potential research opportunities. With that, thank you.
So I'm going to go over what to expect when you arrive in the radiology department for your imaging. Often the first thing that's ordered is plain film imaging. We also call that the chest radiograph, and that's typically the first study that's ordered when a patient presents with symptoms. And we use X-rays to take these images. The patients are usually in the standing position if they're able to stand, and we're either going to take a single frontal view of the chest, or we're going to take a frontal and side view of the chest. And we're going to take a peek at these images to look for the cause of symptoms. So we're going to look for evidence of pulmonary fibrosis, or if you have known pulmonary fibrosis, we're going to look for worsening or improving pulmonary fibrosis. And we're also going to look for other causes of the patient's symptoms, because as Dr. Newton already said, there's lots of causes of shortness of breath, and there's lots of overlap. If pulmonary fibrosis is suspected, computed tomography, CT imaging, is typically performed to confirm this diagnosis. Some people may call this a CAT scan. That's just another term for a CT imaging of the chest. We also use X-rays with CT imaging to obtain images of the lung tissue in 3 dimensions. The images are then reconstructed into slices or thin views of the lung, and we can actually reconstruct these slices into any plane, but the typical plane you'll see is it's called the axial image, and that's what's being shown here in these 2 slices. For pulmonary fibrosis, the images are actually divided into thinner slices than a routine chest CT imaging. And then we actually add a filter to it that makes the images even more sharp looking. And this allows the radiologist to see finer lung details. And that's what's referred to as high resolution computed tomography, or HRCT imaging, just so you understand the terminology that we're using. So just this is the same patient. They had 2 different studies. This is what a routine chest CT would look look like. And you can see that we can see some architectural changes to the lung pattern here. But when we add that high resolution factor and we make thinner slices and we add a computer-assisted technology to sharpen the image, you can actually start seeing that reticulation, that lace-like look to the lung, and we can see the pulmonary fibrosis better. So what to expect when you actually show up at a radiology department. So before arriving for your imaging, there's no specific patient preparation needed. Imaging can be performed at a hospital or at an outpatient imaging center. We want you to wear some comfortable clothes. Try to avoid any metallic details on that clothes because metal can actually cause artifact in our images and make the imaging harder to read. And then leave your jewelry at home if possible. You know, if you have a necklace on, it's hard. If the necklace falls into the field of view, it can cause artifact. This will be a non-contrast study. That means you don't need an IV to be placed in your arm. There's no needles involved. You're going to be placed flat on a table that can move in and out of the CT scanner, and the imaging will be performed at the chest, at your chest level. Now, just so you know, CT scanners are a donut-shaped scanner, and it's open to the room, so it's not enclosed or tube-shaped. That's our MRI scanner. So if a person has claustrophobia, this is usually pretty well tolerated because your face and head are not inside the scanner, and it's open to the space around it. Okay, during the imaging procedure, you're going to have a technologist that's going to be talking to you during imaging. And the technologist will be that person running the CT scanner, and they're going to give you some breathing instructions. So typically you take 2 to 3 scans of the chest during the study. The first scan will be performed with the patient doing a full breath in or full inspiration. And the patient will be lying on their back, and we call that the supine position. So if you see in the image there, you see the patient, they're laying on their back, their arms are up, and that's what's considered the supine position. Once that imaging is completed, we're going to run a second scan, and that scan will be with the patient in full expiration or their full breath out. So we'll ask the patient to breathe out and scan the patient. That'll also be done in the supine position. And then there's a third scan, and this may or may not be needed. If we're going to do the third scan, we're going to have the patient actually roll to their belly and image with a full inspiration. In some institutions, this will be routinely done. In other institutions, you'll have a radiologist take a look at imaging to see if the prone imaging needs to be performed. So that's a little bit of an optional third scan. Each scan will take less than a minute to do, with the total study taking about 15 to 30 minutes, depending on how easily the patient can move. So some people can move really easily. Some patients may need a little bit more time, but just expect to be in the scan room about 15 to 30 minutes. One important factor that improves your imaging quality is holding still during imaging. So trying to hold your breath during imaging and not breathe, trying not to wiggle or move or scratch. The more you hold still, the better your imaging quality will be. Following imaging, there are no restrictions following imaging. You can return to your normal activities.
All right, so I think we can move on to the cases. So we're going to discuss a few cases here where we're all going to kind of walk you through what kind of this multidisciplinary diagnosis discussion. So the first case is a 71-year-old male who's had chronic cough for the last 18 months and progressive shortness of breath for the last 6 months. From a past medical history standpoint, he just has high blood pressure and atrial fibrillation. He's a former smoker, but quit over 20 years ago. He had a brother who actually had pulmonary fibrosis. He's worked as an attorney, and he lives in a house that was built in 2004, has a concrete slab foundation with no prior water damage. And he has no pets, specifically no birds. So his testing shows that his lung function is still fairly well preserved with moderate reduction in his diffusion capacity. And on laboratory testing, everything was essentially normal with negative autoantibody serology testing.
So let's go over the specific imaging findings for the condition known as idiopathic pulmonary fibrosis. We describe this as a usual interstitial pneumonia or UIP pattern of fibrosis. So those terms will often be used together, but the UIP pattern is the pattern that we're identifying on our imaging. So the distribution of findings, this form of fibrosis favors the lower and the peripheral lung, and that's the edges of the lung. It may be asymmetric or uneven in appearance, so the right lung and the left lung might not exactly match each other. And we're looking for findings that extend to the surface of the lung, and we call that the subpleural surface. And just so you know, for anatomy-wise, your lung each lobe of your lung is surrounded by a pleural surface. So that's what we mean by it extends to the lung surface, or that subpleural surface. We're looking for three main features. The first feature is something called reticulation. And reticulation refers to that lace-like pattern of thickened lines that correspond to the fibrotic changes of the interstitium that Dr. Newton already discussed. The second thing we're looking for is something called honeycomb cyst formation, and that refers to at least two rows of holes stacked up on top of each other. So that's a row of these holes. There's a second row of holes. There's actually a third row of holes, maybe a fourth one here. And they're sometimes hexagon shaped, and that's why we call it a honeycombing appearance. It looks like a honeycomb. And then we're also looking for something called traction bronchiectasis. And in traction bronchiectasis, this refers to the enlargement and distortion of the distal airways, typically peripheral airways, or typically the peripheral airways away from the central airways. And this occurs as a result of the adjacent lung fibrosis pulling on or distorting the airway. And so you can see here in the screen marked traction bronchiectasis, the airway is not like a smooth, gently tapering tube. It's actually kind of irregular and zigzaggy looking as it goes out. And you shouldn't see airways that are going out and touching that peripheral surface of the lung. So that's what we mean by airway enlargement. So this is a case of two patients with a UIP pattern of pulmonary fibrosis. So you can see that the fibrotic changes are most significant in the edges of the lower lung. And the fibrosis is characterized by this lace-like reticulation and also honeycomb cyst formation that extends to the surfaces of the lung. You can also see that there are enlarged and distorted airways, and that's consistent with traction bronchiectasis, most affected in the areas of pulmonary fibrosis.
All right, so I'm going to talk to you about what we actually see from the pathology side. So if you end up going in to get a biopsy, you get a piece of tissue taken out. As a pathologist, I'll be looking at that tissue on the slide. So what we do when you get the piece of tissue, either through a transbronchial biopsy or a cryobiopsy, which is where they freeze a piece of tissue, or if you end up doing a VATS procedure where it's more of a not quite completely open surgical procedure, but they go in to take larger pieces of tissue, is then we process that tissue, we fix it in formalin, which makes the tissue very stiff. And then we process it through a number of different chemicals. And then we actually embed pieces of that tissue into a paraffin wax. And then we take that paraffin wax and we cut off an extremely thin section, 4 microns. So to give you an idea of what that means, a strand of hair is about 70 microns. So it's even thinner than what you see in a strand of hair. And so then we take that very, very thin slice of your lung and put it on a glass slide and then put stains on it so it has colors. And then we're able to examine down to the cellular level what your lung looks like. So I first wanted to start off with an example of what normal looks like. So to give you an idea, this piece of lung that we're looking at is maybe 2 centimeters in size. So this is the microscopic view. So Dr. Jocelyn just talked about the pleura. So you can see on the top part of this, the pink line on the very edge on the top of the screen, and on the bottom of the screen is your pleura. It's normally very thin. And then all the empty spaces you're seeing are your alveolar sacs. If you look kind of on the right middle side of the image, you see a circle that has some blue on the inside. And then above it, you see it's kind of a little bit more of an oblong circle that has some red in it. So the circle with the red in it on the top is a pulmonary artery. So that's a blood vessel. And then it runs with an airway. And so that's your airway underneath. And so we call those the bronchovascular bundles. So that if you think about your lungs as kind of a tree, you start out, you breathe in air through your trachea, and then it branches off to either side of your lungs and branches smaller and smaller and smaller, kind of like the roots of a tree. And so when we look at pathology, we think about converting the 3D reality of what your lung tissue looks like to a two-dimensional picture, since we're essentially taking a slice and then looking at it. And so this is what a normal lung should look like. Lots of open, empty spaces. The white is where the air would be. And then the tiny little lines you see is where air exchange, where oxygen goes into your red blood cells, and then carbon dioxide is taken out of your of the blood. So that's where all the air exchange happens. So this is what normal lungs should look like. So now I'll show you an example of what a patient with idiopathic pulmonary fibrosis lung might look like. Now, for a lot of people that are diagnosed with IPF, if they have a very specific, very nice usual interstitial pneumonia pattern of fibrosis that Dr. Jocelyn would see on imaging, you may not have to get a biopsy at all. And so we actually don't see this as much in pathology, because for patients that fit the right demographics, say you're, a 70, 75-year-old man, maybe you have a strong smoking history, and then you have those distinctive findings of a UIP pattern of fibrosis on imaging, you probably won't need a biopsy. Radiologists are very good at identifying this pattern. That said, if you have more of an atypical presentation, kind of like what Dr. Newton was talking about, sometimes all the pieces don't quite match. Maybe you're not an older man, but maybe you're a middle-aged woman, and it would be very unusual for someone like that to have IPF, essentially. So then we start to think more about some kind of autoimmune disease, or maybe exposure to birds or something else like that. So those would be examples where we might actually have a tissue from a patient that has more of a UIP pattern on imaging. So if you look here, you can see, in contrast to that normal lung I showed you before, you can see in the normal lung here, it's quite empty, all those empty spaces, right? Just very thin lines for your septa. But then when you look at this lung, it looks a lot more pink, right? And so all of that pink is collagen. So that's collagen fibrosis. So if you, for example, if you get a paper cut or something, or you cut yourself, you might get a little scar that forms there, right? And so all that pink that you're seeing here is scar actually in your lungs. And so for an IPF case, the UIP pattern has this distinctive look where the scarring forms almost like a donut around the normal appearing lung. So if you look on the right side of the image, you can see that there are some open spaces there, more like what that normal area, but then it's almost like that pink scar is wrapping around it and the inside is normal. And so that's what we call a spatial heterogeneity. So it's kind of a big words, but basically what we're saying is that you have areas of normal versus areas of abnormal that are right next to each other, and you can almost draw a line through them. And then if you look on the left side of the image, you can see some of that honeycomb cystic change that Dr. Jocelyn was showing you on the imaging. And so it has kind of a little blue lining. That's your respiratory lining. So the type of lining that normally lines your respiratory tract. So these are the cells that help move mucus out of your lungs. And so in honeycomb change, you see abnormal spaces forming these kind of cyst-like spaces, and all of the material inside, you can see there's kind of a grayish material on the left is mucus. Because if you think about it, if you have these abnormally dilated spaces, it's going to be very hard for those cells and their tiny little cilia to beat all of that material out. And so you get mucostasis, you get mucus build up in these areas. And as you can imagine, in these areas with this honeycomb change and all this fibrosis, you can't actually have gas exchange going on. And so that's, of course, why then you have trouble breathing. So my next slide here is showing you a very, very, very close-up view. So this is probably just a couple of millimeters of tissue that we're looking at here. And in the middle, where I have the arrow showing you the leading edge of the fibrosis, is something we call a fibroblast focus. And so you may see that in the descriptions on your reports for your wedge biopsies that you get back. And a fibroblast focus is basically new fibrosis. So, we talked about the collagen fibrosis, which is kind of that pink scar. If you look on the left side of the image and the bottom of the image, you see a deeper pink material. That's that scar, that's that collagen. Versus if you look on the surface of that bump, it has a little bit more more of a bluish look to it. It looks a little looser. So that's that new fibrosis, and that's what a fibroblast focus is. So this is the leading edge of the injury pattern that's happening. And we don't really know what causes this, hence the name idiopathic, which is basically a word for saying we don't know the cause. And so this is showing you what that leading edge of the fibrosis looks like. And so this is one of the histologic features that we look at when we're trying to make a diagnosis of IPF in a patient. And I should add, though, just not to be confusing, the fibroblast foci can actually be seen in other causes of fibrotic lung disease. They're not specific for a UIP pattern and IPF, but you do need to see them in order to make a diagnosis of a UIP pattern and IPF. All right, and then the next picture here that I have is just a little bit of a higher power image showing you the details of what that honeycomb change looks like, those cystic spaces with the mucus. And so the blue are the nuclei of all the cells that are lining, that's respiratory epithelium. You may be able to imagine here, I don't know how good the resolution is on the projection, but if you look on the inside of these circles, you can see what looks like a tiny little fuzzy border, and those are actually your cilia that are beating to move all that mucus up. And then around these irregular spaces, you see this deep pink material, which is the collagen. So this is fibrotic. So these areas of lung are not participating in gas exchange. They're not helping you out to breathe. All right.
So for this patient, we made a diagnosis of idiopathic pulmonary fibrosis based on the story in the CT and the PATH, and we started them on antifibrotic medications. So we're going to go through the next case here quickly here. So this is a 63-year-old male, also has had a chronic cough for 18 months with progressive shortness of breath for the last 6 months, but also has noted some joint pain and swelling in his hands and knees. His prior history has had a heart attack in 2009. He's also a former smoker, quit in 2013. Has a sister with rheumatoid arthritis. Worked as a nurse, but retired due to joint pain in 2020. Lives in a house built in 1994, no water damage. Has 3 dogs, no birds. On testing, had FVC of 72%, so a little bit low, and DLCO is also a little bit low at 66%. Had normal liver and kidney function, but had positive serologies for rheumatoid factor and anti-CCP, which we can commonly see in patients with rheumatoid arthritis. We sent this patient to a rheumatologist, and they made a diagnosis of rheumatoid arthritis.
Okay, so there's actually a question out there in the audience. So what's the difference between UIP and NSIP in a high-resolution CT scan? So this is going to kind of answer that. So there's 2 types of the NSIP pattern of pulmonary fibrosis. It can be the fibrotic type or a cellular type. They both have it's a relatively symmetrical pattern bilaterally, and again, the imaging findings favor the lower lung. In the cellular form, you're going to see ground glass opacities with a lower lung predominance. You're going to look for something called subpleural sparing, and that means that the fibrotic changes don't necessarily involve the edges of the lung, and this is a pretty specific finding for NSIP. And it's often a peripheral process, but can be diffuse or central in location. There's also a fibrotic form where reticulation is present. This may be a fine reticulation. We'll look for traction bronchiectasis again, but it tends to be more mild than IPF. And we're going to look for thickening along the airways and the central vessels, also known as bronchovascular bundles. And I just wanted to show you a quick picture of what ground glass opacity looks like. So this is a jar that has a glass portion and then this like buffed portion of the glass. And that's this part here is what ground glass looks like, where you can kind of see the pattern through the ground glass, but you can't, it's not a perfect look. And that's what we're looking for when we're talking about ground glass opacities. So this is a patient with NSIP pattern of pulmonary fibrosis. This is the cellular type. And what we're seeing here, like UIP, the changes favor those lower lungs. But instead of all that reticulation we saw last time, it's going to be diffuse ground glass opacities present, tracking along the airways and the blood vessels. And note the lack of the honeycomb cyst formation. We see some mild airway dilatation, so it's consistent with mild traction bronchiectasis, but it's not as bad as IPF. And we can see that some of the abnormalities don't go all the way to the edges of the lung. And that's that term of subpleural sparing, a pattern that's pretty specific for NSIP.
Okay, so now I'm going to talk about some of the histologic findings that we can see in patients who have underlying connective tissue diseases like rheumatoid arthritis. So there's two main patterns that we see, although there are others. The first is the NSIP pattern, or nonspecific interstitial pneumonia pattern of fibrosis that Dr. Jocelyn mentioned. And then the next is lymphoid interstitial pneumonia. So again, just to show you an example of what normal lungs should look like, nice thin alveolar septa with open white spaces everywhere for gas exchange to take place. And then here's what is actually a pretty severe example of mostly fibrotic NSIP. And I show this to highlight, this is at the same magnification as the previous photo that I showed you. And you can see that you have marked pink material filling those spaces and almost what appears to be kind of like oversimplification and a fewer open spaces. This is extremely fibrotic. There's no oxygen exchange that's happening right now in this particular case. And of course, there are variations. It's not always going to be that bad. And if you have more of a cellular process with more individual like lymphocytes and plasma cells, that can be reversed potentially with medication. So the next example that I have is lymphoid interstitial pneumonia. So this is not an uncommon pattern seen in patients that have systemic connective tissue diseases like rheumatoid arthritis. And the first thing I hope that strikes you when you look at this photo is how blue it is. That's because it's very inflammatory. You have lots of lymphoid aggregates, so those kind of blue balls floating throughout. And then the alveolar septa, instead of being thin and small and kind of hard to appreciate, are actually filled with blue cells. And those are all a mixture of lymphocytes and plasma cells. So here's a little bit of a higher power image showing you those findings. And again, I have normal lung in the upper right-hand side at the same magnification where it should be very small, just capillaries in there. But instead you have this marked thickening of your alveolar septa by a mixture of fibrosis and lymphocytes and plasma cells, and then also these rounded blue areas, which are lymphoid aggregates. So basically a lot of white blood cells that are getting together to form these reactive follicles. And so this is a common pattern that you'll see in patients that have underlying systemic connective tissue diseases like rheumatoid or Sjogren's or any other number of diseases. And, sometimes patients present initially with pulmonary manifestations. They don't have a known diagnosis of rheumatoid arthritis or something like that. And then oftentimes they never actually have a diagnosis of an underlying rheumatologic malignancy, but the findings on the histology are quite convincing for that. And then there are a set of patients, again, it can be quite challenging, as I'm sure Dr. Newton can attest to, for patients that have pneumonia with autoimmune features, essentially. So we call those IPAF patients, and LIP is a very common pattern that we see in those patients.
So for the second patient, he was diagnosed with rheumatoid arthritis-associated interstitial lung disease. And he was started on anti-inflammatory medications to see if that would help preserve lung function and even help with some of his joint aches and pains. So the last case we have here is a 53-year-old female, has, again, chronic cough for 18 months and progressive shortness of breath for 6 months. You can see that sometimes these presentations are quite similar. She has a history of seasonal allergies. She's a never smoker. She has a father with lung cancer, but no other family history. She works as a florist, lives in an apartment that was built in 2014 and flooded in 2019. She has 2 cockatiels for the last 8 years. So we have a couple of red flags there. Her testing shows a little bit more severity of impairment in her lung function. Her FVC is 52%, DLCO is 46% predicted. Her laboratories are essentially normal. She has normal liver and kidney function and negative autoimmune serologies.
Okay, so we're going to talk about fibrotic hypersensitivity pneumonitis in this case here. This is also known as chronic hypersensitivity pneumonitis. And the distributions of findings in this case, we're often going to see these findings favoring the mid and upper lungs as opposed to the lower lungs. And someone did just ask a question about distinguishing IPF from hypersensitivity pneumonitis. So hopefully that answers this question. The IPF or UIP pattern and the NSIP pattern favor the lower lungs typically. On imaging, I'm going to look for that reticulation, the traction bronchiectasis, and the honeycombing again, but we're going to suggest that this is due to hypersensitivity pneumonitis if we see it in the anterior and upper lungs. And I'll show a picture of that in a couple minutes, or actually on the next slide. The finding that we're really going to spend some time looking for is evidence of air trapping on expiratory imaging, or when the patient takes a full breath out. And we're looking for geographic or mosaic areas of hyperlucency, which are dark appearance, causing blockages of the small airways. And if acute inflammation is present, we may also see ground glass opacities and small nodules surrounding the small airways. So unfortunately, I can see here the picture got offset a little bit. So my little asterisk and my little arrow don't quite match up where I had originally put them. So I apologize for that. But what you're going to note is that the back wall of the trachea, and if you picture that arrow moving over a little bit and down a little bit, you're going to see the back wall of that trachea bowed in, and that indicates that this patient's in the middle of the exhalation. So that was that second scan I talked about. And we're looking for these pockets of hyperlucent or extra dark portions of the lung that are identified consistent with air trapping. And that air trapping is really going to help us distinguish hypersensitivity pneumonitis from other causes of interstitial lung disease. So this is a patient with a history of repeated bird exposure. And you can see this reticulation and honeycomb cyst formation and traction bronchiectasis in the anterior and upper lungs. That's where those circles are. And the patient also had a little bit of emphysema, and you can see those changes in the peripheral lungs marked with the asterisk. On the expiratory imaging, you're going to see these multiple pockets of air trapping throughout the lung. And that tells us this is something different than NSIP, something different than UIP.
Okay, so I'm going to talk to you about what we see in a biopsy in a patient who has hypersensitivity pneumonitis. Now, what we see is variable depending on how far along in the disease that the patient is. And if you think about this disease, it's a reaction to bird antigens usually. It can also be reactions to mold, hay. There's the whole huge list of things that can cause HP. And so since it's a reaction to something you're inhaling, you're going to see those findings on histology around the airways, which makes perfect sense since it's from something that you're inhaling. So let me show you an example. Again, I'm just like to show that normal lung in comparison to what we're seeing. And then here's an example of a patient that has a pretty mild chronic HP, but if you look on this low power image, if you look in the middle, that's a bronchovascular bundle. So that's your airway, right? And then that sort of wiggly worm thing sort of near the bottom is the pulmonary artery. Remember, 3 dimensions to 2 dimensions. So it just depends on how we're cutting the tissue will change what we actually see. And then so around that airway, you see blue. So we're seeing inflammation. And then in my inset in the upper left, you can see what we call a granuloma. So this is basically a giant cell, some epithelioid histiocytes, basically a bunch of chronic white blood cells all mixed together. So anytime you have chronic irritation that the body feels like it can't clear, in this case, it's a hypersensitivity reaction. So there's really nothing that's actually hurting you, but the body sort of gets confused. You can have granulomas that form. And then you can have some fibrosis over time that can form starting in the airways and then moving outward. So here's a higher power picture showing you the granuloma that you see in a case of HP. This patient had more on the cellular side. They weren't getting fibrotic yet. So all those cells that are kind of loosely collected and they're in that open space where they shouldn't be, that's a very classic look for what we call an HP granuloma. There are granulomas that can be formed by a lot of other things. You can see them in patients with sarcoidosis. You can see them with patients who are aspirating. So they're basically breathing bits and particles of food and gastric material that they shouldn't be. You can see them in drug effects. You can see them in systemic connective tissue diseases. So they're not specific, but the quality of the granuloma is your key. So if you're looking at those pathology reports and you see loosely formed airspace granulomas around the bronchovascular bundles, that's going to be more in keeping with a granuloma you would see in a case of HP. And I think that's my last picture slide. Oh, no, I have one more here. So here's just a little bit higher power photo of that earlier picture showing you the airway. And you can see, again, those sort of blue dots around the airways, that's inflammation. Those are white blood cells, chronic white blood cells that are known as lymphocytes. And that's chronic bronchiolitis. And so you have this sort of chronic irritation in your airways. You may be coughing. You may have, mucus that's hard to get out. So an interesting thing, sometimes patients with chronic HP that maybe goes a long way before it's treated, they can actually develop a UIP pattern of fibrosis. And so in those cases, you really need probably a biopsy to make the diagnosis, because then you're looking for those granulomas and you're looking for those giant cells. You're looking for those signs that tell you this started as an airway-centered process. Sometimes you can see that on imaging, but oftentimes you may not. And then I'd like to point out that the differential diagnosis here is maybe a patient who actually does have IPF and is aspirating, because when you aspirate, those food material gets into your airways and irritates your airways. So that might give you air trapping on top of a UIP pattern. So I think chronic aspiration and IPF can be challenging without a biopsy to differentiate between chronic HP with a UIP pattern. All right, and this is just one more high power picture showing you what we call small airway remodeling. So anytime you have chronic injuries to your airways, whether it be due to bird antigen exposure or aspiration or even infection, your body tries to compensate. And so you'll get what we call peribronchial metaplasia or small airways remodeling. You basically have those respiratory cells, the lining cells, spreading out beyond the airways that they're at. And so then, of course, those areas are not functioning in gas exchange.
So for this patient, we made a diagnosis of fibrotic hypersensitivity pneumonitis. We recommended avoiding those exposures. So even potentially sometimes we have to recommend moving out of an apartment or removing birds, and then consider anti-inflammatory medications to help preserve lung function.
Okay, well, thank you all for that super presentation and sharing your knowledge with us about the diagnosis of pulmonary fibrosis. Now we're going to move to the question and answer period. We have several good questions, and we're going to try to get to as many as we can. The organizers have allowed us to extend our time a little bit to 11:40, so we will try to get to as many of these as we can. The first question is, how does pulmonary hypertension affect my lungs? And if I may, I'll take this question. So as lung fibrosis gets worse, many patients will develop pulmonary hypertension or high blood pressure going to the lungs. There are certain subpopulations of patients, such as those who have emphysema with pulmonary fibrosis, or those who have autoimmune diseases like lupus or scleroderma, where it may occur earlier. But as things become more severe, you may develop pulmonary hypertension. So in this regard, how does it affect your lungs? It affects gas transfer. It affects the oxygen transfer into the bloodstream. And so symptomatically, an increased shortness of breath with exertion if you had pulmonary hypertension versus if you did not. There is a new medication that has been approved for this as about 1.5 years ago. It's called Tyvaso. So it's something that can be considered. Does anyone else want to add anything to this answer? If not, we'll move to the second question.
Pulmonary hypertension can also affect the heart too, and it can lead to right heart problems. So it's something, as your lungs worsen, I'll see on imaging that the pulmonary system then gets worse or gets larger in size, and then it can back up to the heart. So it is worthwhile being aware of it, and it'll be something that needs to get followed over time.
Very good, thank you. And the second question is, where does all the phlegm come from? Is it only caused by bronchiectasis?
Yeah, I think I can take that one. So phlegm is normally produced by the lungs. So even people without pulmonary fibrosis can cough and get phlegm up. In some patients with pulmonary fibrosis, it tends to be a little bit more prominent. Either maybe the areas that are involved or the type of pulmonary fibrosis may be associated with a little bit more phlegm production. Also, there's other causes of phlegm production in patients, right? They can still have allergies and postnasal drainage. Some people, like Yasmin was talking about earlier, have some aspiration, and that may produce some phlegm. And so when one of my patients is complaining of either increased cough or increased phlegm production, I first want to make sure that there's not something else that I can easily intervene upon, like allergy medications or acid reflux medications. And if it's from the lungs, then we really work on trying to help either with clearance of that, so with sometimes with bronchodilators or inhalers or other devices to help kind of get it up, or with even sometimes cough suppressants. So it's a little bit different for everyone, and there's lots of potential causes that we can try to address.
Thank you, Chad. Next question is there updates for finding molecular biomarkers in interstitial lung disease? This is a great question, and it's a hot area of research right now. I would encourage you to go to the PFF website page and look at something called Prolific on there, which is an effort to identify biomarkers to identify whether someone's getting worse or not. People are also trying to identify biomarkers for the diagnosis or earlier detection of the disease as well. So stay tuned. A lot of great papers coming out that are not quite yet published, but very good question. Is there some other comments in regard to this?
Yeah, I can add a comment to that. I definitely agree there's tons of research being put out there, but still just to take everything with a note of caution and carefully look at the research behind it. One example that comes to mind is the Envisia test. I don't know if any of you have heard of that, but it's touted as a way to identify if you have a UIP pattern of fibrosis or not. However, I'd just like to point out that it's agnostic of etiology. So if you have an underlying UIP pattern due to hypersensitivity pneumonitis or systemic connective tissue disease, it won't be able to identify that. And so in patients like that, especially if your demographics don't quite fit, just being given a diagnosis of UIP doesn't necessarily mean you have IPF. And even if you have a pure UIP pattern, you may have that pattern due to an underlying systemic connective tissue disease, a strange adverse drug reaction, something like that. So always to take the new molecular tests with just a grain of salt, and discuss them with your pulmonologist.
Good, thank you. Question number 4, what came in early and it was addressed a little bit later in some of the cases. They were talking about UIP versus NSAP and an HRCT scan, but I think that was very, very well addressed in one of the cases. Question number 5 is how often should a CT of the chest be taken to monitor progression?
So I think I could take that one also. So it's a really good question, and actually is a little bit controversial within the field, is we're starting to try to quantify or come up with objective markers for progression. Right now, there's not specific guidelines on how frequent we should be doing high-resolution CT scans for our patients, but most pulmonologists would recommend initially getting a CT scan, right? We need one up front to be able to render a diagnosis or come up with potential diagnoses. And then most of us, if we will follow spirometry or pulmonary function test and symptoms and exercise capacity over time. And if there's a significant change, then we'll repeat a high resolution CT scan at that time to see if we also have evidence of radiographic progression. There's also some other reasons why we might want to repeat a CT scan that is not necessarily related to the pulmonary fibrosis, but when we do scan, sometimes we see something that we didn't expect to see, and some of those things need to be followed over time with regular imaging. So over the next year or two, we may get updated kind of recommendations on doing repeated CT scans at specific intervals, but right now, most of the time, it's driven by a change in the patient.
So we have a question that relates something to that something else that might be seen on the CAT scan, and that is, do patients with IPF have a greater incidence of lung cancer? So the incidence of lung cancer in patients with IPF is around 8 to 10% in a couple of different studies that have been done. So there certainly is that possibility. Many patients with idiopathic pulmonary fibrosis have been smokers, maybe 2/3 in the past. Yeah, so it certainly is possible to have both. Any other comments on that?
Yeah, I just wanted to add, and sometimes it can be really challenging to diagnose that cancer. Since there is so much fibrosis, it can be hard to see on imaging, and certainly Dr. Jocelyn can talk more to that. And so not uncommonly, I will see wedge biopsies for interstitial lung disease, and we do find cancer arising in them. Another possibility, which is thankfully quite rare, but it does occasionally happen, a patient will be diagnosed with interstitial lung disease, and then actually what they have is bilateral diffuse cancer. Thankfully, that's quite rare, but it does happen occasionally. So I would always say, if there's ever a question about the diagnosis, if something doesn't quite fit on imaging, something just doesn't seem quite right, to always consider getting a tissue diagnosis to know what exactly is going on.
Yeah, as far as the imaging is concerned, what we teach our residents is that patients with pulmonary fibrosis have a higher tendency to have pulmonary nodules, but every one of those pulmonary nodules has a higher risk to become a bad player. So it's a busy sets of images to look at. We have to look at them carefully, but I have a low threshold if I start seeing a nodule grow, a nodule change, to call that it might be something we need to take a closer look at. And it's the same with the lymph nodes in the chest too. We didn't talk about lymph nodes at all, but lymph nodes tend to be bigger in patients with pulmonary fibrosis. It tends to be more of a reactive process. But if I see one of those lymph nodes start growing out of proportion to the other lymph nodes in the chest, again, I have a very low threshold for saying, let's take a second look at that. Let's maybe get a tissue sample. And it's just something very good to know about. That's just our traditional teaching when we're looking at patients with fibrotic lung disease.
Thank you. So the next question is, how can I exercise when I have a hard time breathing? Chad?
Yeah, I can take that one also. So it's very difficult. And this comes up fairly frequently, actually. Once the pulmonary fibrosis gets to a certain point or the lung function is at a certain level, it's very difficult to do your even activities of daily living, walking around the house, preparing meals, going shopping, things like that. And so it makes it even harder to exercise. There are regimented exercise programs like pulmonary rehabilitation programs that can educate you on how to actually do it and the types of exercises that you can do. So I have lots of my patients get, arm pedal devices where they're not up walking around, but they're using their arm pedals to kind of get their heart rate up for a little while. And I have them try to extend the time in which they do whatever exercise they're able to do a little bit longer, every week, right? So we set small goals and say we're going to, walk or do the stationary bike or the arm pedals for 5 minutes, one time a day or 2 times a day. And after a week or two, we try to increase that a little bit. It's kind of like a runner training for a marathon. When they first start running, it's really difficult. And over time, it's not that it gets easier, but they kind of get used to it a little bit more and are able to do more activity. And so that's kind of what our approach is. And again, I think using these pulmonary rehab programs that are a lot more available now to patients is helpful because you're able to do exercise while being observed by nurses and respiratory therapists to let you know that your oxygen levels are okay, you can keep going, or this is the time in which you might need to stop and sit down, catch your breath for a second, and then go again. So I think those are quite helpful.
Right. So shortness of breath can be from many causes. One can be the lung fibrosis itself and the low oxygen, but others can be deconditioning. I'm the only one on the panel that remembers the Apollo flights, and these were the best and strongest, and they were not conditioned because they were in space for a week, and they were very short of breath coming down the stairs from the planes at the end. So adding the deconditioning on top of the oxygenation problems is not good. So try to get yourself conditioned. The studies show that it leads to a better quality of life. Okay, the next question we have here is, why does it take 8 to 12 months to get the results?
I'm not sure if they mean pathology results, and I'm not it should never take 8 to 12 months for a pathology report. It typically takes me from 1 to 3 days to get a report out. If I don't need to do any special stains looking for like an infectious cause, like looking for bacteria or fungus, I can sign that out the day I get it. Otherwise, it might take an additional 1 or 2 days to do stains. Certainly, it shouldn't take less than a week to get pathology reports back. Occasionally, people will send these cases out for consultation. So we see a large number of consultation cases from all over the country for interstitial lung disease. But even then, I would even if they take a couple of weeks to get the case to us, we'll turn it around pretty quickly. 8 to 12 months seems not ideal. So I'm not sure where that person is getting their results back. It should not take that long, to answer your question. It should not.
Yeah, we know there is a PFF published on this. There is a delay in making the diagnosis from the time a patient presents with symptoms. And so this is part of the education process that the PFF is involved in to help doctors and patients understand better that being short of breath, even if you're 65 or 70, isn't right. And so to try to accelerate this identification that you may have pulmonary fibrosis to get therapy started sooner. So question number 10 here is, how do we know if the antifibrotic medications are working?
Yeah, I'll take that one. That's another fantastic question. It's difficult to know if the medications, any medications, not just antifibrotics, but other medications, are working in an individual patient. So what we typically do is kind of the slide that I mentioned, where we look at the trend in objective numbers, lung function, patient-reported symptoms, and even walk test distance, things like that we can follow over time and see how the trend of those changes before we start treatment and how they're changing after we start treatment. Again, the goal of our medications is that we're able to slow down the progression. So if we see that someone is declining quickly and we institute therapy, our goal would be that the decline slows after that. It's hard to know what would have happened in a patient if we didn't start medications, right? Because that clearly changes things. But our goal here is stability, and oftentimes it requires medications to achieve stability depending on the diagnosis.
Thank you. The next question is, can you take both antifibrotic medications at once?
Yes, actually, this is being looked at. So right now, probably not. There's a couple of reasons for that. Number one is primary side effects, right? So neither of the antifibrotic medications are without side effects, and a portion of patients will have side effects. The worry is that if we start adding these together, then maybe they'll have even more side effects. But this is actively being looked at. There are small studies that have used both medications because they do work kind of in different pathways. So there's some thought that they may be synergistic or they may have a better effect if used together. But we just don't know if that's true, if we'll get additive benefit by using both. We also don't know how severe the side effects would be if we use both in a larger group of patients. But that is something that is being actively studied. And also, too, with some of the other drugs that are in the pipeline, most of these phase 3 studies are set up in a way that we're allowing patients to already be on FDA-approved antifibrotic medications. So if these new drugs work, it will be in addition to already being on other medications. So it's an exciting time, and hopefully we have more definitive answers to some of these questions over the next few years.
So I'd like to add to that. So if you're on an antifibrotic medication and you feel you're getting worse, my bias is to get involved in a clinical trial with another drug. I mean, many of us have high blood pressure, and it takes more than one medication to get our blood pressure under control. So why would it be any different for pulmonary fibrosis? I would encourage you, if this is a situation for you, is to go to the PFF website and the trial finder, where you can find a trial near you. All right, the next question is acid reflux being considered as a cause of pulmonary fibrosis?
So on imaging, I can easily see, there's definite imaging patterns of chronic aspiration causing chronic fibrotic changes in the lungs, and sometimes it'll be acute on chronic because people that aspirate tend to continue to aspirate. So it's a specific imaging pattern I'm looking for. I can actually see like bony changes that actually happen in the lungs due to chronic aspiration. So it is a cause of fibrotic lung disease, but it looks different than IPF or UIP pattern. It looks different than an NSIP pattern on my imaging. It has a pretty characteristic pattern of findings, but it's definitely a cause of fibrotic lung disease. We just didn't include it in this group.
Yeah, and I completely agree. And it's not uncommon also to see chronic aspiration-related fibrosis in addition to IPF or another possible etiology. So sometimes you can see these combined patterns, which I think also answers another question on there. Can you have two diseases at once? And the unfortunate answer is yes. Yes, you can.
So we have just a few more time here for questions. Here's a quick one. Would living at a lower elevation help slow progression of pulmonary fibrosis? And I'll answer that one. So I don't think there's any knowledge as to whether it would slow the progression of pulmonary fibrosis. You'll be a whole heck of a lot less short of breath at a lower altitude, though. The partial pressure of oxygen at altitude that makes it hard to breathe. So I think we're going to have to close our question and answer period. I apologize that we didn't get to all of them. There were so many good questions. I do want to, if your question didn't get answered, again, on the Pulmonary Fibrosis website, there's a call center, and you can either type in a questions there by email, or you can actually speak to Jem Simkavatis live, and she can help you with these questions. So I do encourage you to make use of that avenue. Okay, so we have a great schedule of sessions today. You can find the agenda in the lobby of the platform. I do want to thank our speakers again for their expertise and time in helping us today. Coming up next then, and I have to click a slide here, we would have these clinical trial innovation series at noon, and the exhibit hall, we've eaten a little bit into that time for that as well. But I hope that you'll catch whatever you can in this regard. I'd also like to highlight our last session of the day, the All Community Networking event. And during this event, you'll have the chance to meet with others in the community who have a similar connection to pulmonary fibrosis. And so there'll be breakout sessions that'll be available for patients who've got pulmonary fibrosis, people regarding those needing oxygen, lung transplant recipients, caregivers, friends and family, and people maybe who have lost a loved one to pulmonary fibrosis. Thank you very much for your time and attention today.